All right. Well, thank you. Thanks for coming back. It's good that you're still here. Any questions that came up? Anything? Feel free to ask anytime. How about the pace? Is everyone understanding everything okay? Am I talking too fast, or is it okay? All right. Feel free to let me know if you need me to slow down. Thank goodness I'm live in California now. If I lived in New York, this would be even worse. The speed and the accent would be even worse. So California has changed me and chilled me out just in general a little bit. So it's nice to be in California. All right, so let's talk about some lower urinary tract interventions. This is one of the areas that has definitely seen the biggest expansion. I would say if you're looking at trying to incorporate IR into your everyday practice, this is one of those areas to start to think about. We see a lot of lower urinary tract obstructions, lower urinary tract disease, even things as simple as seeing obstructed cats. One of the big things that's been, don't want to overstate this, but almost life-changing, at least in the area of de-obstructing cats, is just the use of guide wires. Makes it so much easier. Guide wires want to go past obstructions, and so using things like little guide wires just dramatically improves some of the things that we can do in our cat patients. So just something to think about. That's a case that we all see every day, cats that come in obstructed from lower urinary tract disease. And so yes, we can talk about tumors, we can talk about ballooning, all sorts of wild uses of different IR treatments, but this is one of the areas where there's basic things that we can do on a daily basis. And so I'm going to mostly just focus on kind of these 6 different procedures just to kind of give you an overview of some of the lower urinary tract applications we have and hopefully help you think of ways that you might start to incorporate this into your practices as well. And so first we're going to talk about ballooning and stenting of benign strictures. And so these are benign strictures. These are not those cancer-specific ones. We'll talk about cancer here at the end, but these are those ones that happen most commonly from us. We're trying to pass a urinary catheter, we're trying to unobstruct a patient, and we end up traumatizing the urethra. That's the most common cause of stricture formation in cats. Because cats usually don't have stone disease specifically, but when we're trying to pass catheters and things, it's not unusual for us to stricture them. Dogs can tend to more commonly get strictures in their urethra from having stone disease. So dogs more likely to be from stone disease, cats more commonly from iatrogenic causes. And so one thing to consider in this situation is ballooning. And so we like to perform ballooning oftentimes as a solo procedure to see if that is enough to open up a benign stricture. If you balloon a patient and just have to balloon them, then you can avoid potentially leaving some sort of implant in them long term. And so whenever possible, I shouldn't say this in here, but whenever possible, we don't want to leave implants in, so we try to avoid that as long as possible. But eventually we might have to get to that point. But if we can start with ballooning, that might be an alternative to potentially getting us a patient that's able to pass urine when they weren't previously able to do that. We usually use a high pressure but a low volume balloon. You don't want to get one of these balloons that gets super huge. Urethra is small, right? Even in a big patient, urethra is small, but you want to get one that can generate a high pressure. These strictures are very resilient. You have to push on them very hard to open up. And so one of the things, and we'll look at a case example, that one of the things that you have to deal with sometimes is sometimes they will actually rupture. So what equipment do you need here? Again, we need our introducer sheath, so we need to have access into the urinary system. We need our guide wire, of course, catheter and contrast to try to help us delineate exactly where the stricture is. Of course, the balloon, and then plus minus a stent. So here's an example. This is a case. This is a benign urethral stricture, and I'll tell you what happened in this case. So this is an unfortunate case. This was a dog that had a cryptorchid testicle. And I've seen this happen now a decent amount of times, but as opposed to the cryptorchid testicle being taken out, they took the prostate out. And so we do see that from time to time, people that are less comfortable maybe with some of these surgeries, they'll sometimes have that. They're in a similar location, potentially a similar size, so you have to be a little bit careful when you see the prostate and its location, and just making sure that identifying a cryptorchid testicle versus the prostate, very, very important. So this is a case that had an inadvertent prostatectomy. After it happened, they realized it happened, and then sutured the urethra back together again, and then from there it's strictured. And that's most commonly when we see strictures. We see strictures most commonly when you do a 360 cut. right? We use the term stricture a lot when we talk about any kind of luminal narrowing. But in reality, a true stricture happens when you have a 360 incision, because a stricture is when all of that tissue all the way around actually tightens down in a location. Yes, we can see luminal compression or luminal changes just from having an incision on one side. You could see it close down, but technically a stricture is that kind of 360 closing down. And so this would be that classic case. For anyone in here that hasn't seen a prostatectomy or kind of gone through that process before, you basically have a complete removal of the urethra in that region. And so you have urethra end, and then you put them back together. So that's what we're dealing with here. We have this dog had a prostatectomy and now can't urinate after having the urethral anastomosis performed. So we do our contrast study. This is the pre-dilation urethrogram. So it makes sense. Right here's our prostate, right, or where the prostate was. This is where the surgery was. And so you can see some urine was getting through, so the dog didn't obstruct immediately. This wasn't immediately post-op. This was several weeks down the road. And you can imagine there's maybe a little bit of a wisp of contrast getting through here, so that's why this dog didn't present acutely obstructed. But just very, very small, and so struggling to urinate through that little opening right there. You're getting some through because we're giving our contrast back here. So we're doing our contrast cystourethrogram back here, and you can see the bladder's filling, so there's some level of opening, even though if you look really close, it's hard to see where that opening would be in here. So it makes sense that both of these things are happening, both that the dog did not acutely obstruct, but also that the dog is having a big time challenge with urination. And so here's an example placing a balloon, and immediately you could see that with the position of this balloon, you could see just how severe the stricture is. The waist, we call it the waist of the balloon there, where it's compressed down. It's like a corset in there, just squeezing it down. Right there at that level of the waist, that's where the stricture is. And you could see that just how tenuous it is and how challenging that might be, tenacious it is, and how that might be really, really challenging to open up. So you have to use a balloon to kind of generate that pressure to open it up. And oftentimes we'll use balloons that you'll probably hear about some tomorrow, but we'll oftentimes use cardiac balloons they use for valvuloplasty, because you really need those high pressure balloons in there. And so any balloon that kind of gets the job done. And so at this level, if we open this balloon to this point, you could say, okay, a dog could urinate out of that level of stricture. Yes, it could at this point. But what's going to happen is if you don't fully break down the fibers of that stricture and open that area up, it's going to immediately collapse down again, or at least in the first week or so. So you don't want to ever leave a stricture undilated just to this point, or only dilated to this point. So you want to keep adding pressure. We're going to keep putting pressure on that balloon, continue to dilate it, and eventually we're going to get it to open up. And so we've done several dilations here now on this case. And after enough dilations, we've been able to finally get it to open up completely. And you see it open up completely because you see the balloon completely open. You eliminate that waist that's in the middle of the balloon. And sometimes you have to kind of progressively increase the size. And it's not just about the diameter of the balloon. It's about truly eliminating that waist. And so whether you have to increase the pressure in the balloon or whether you have to increase the size of it, you have to kind of think ahead about what you might need to potentially do in that situation. Yeah?
Is this in separate anesthetic events, or is this separate in time?
Yeah, good question. So is this separate anesthetic events, or was this over different times? So both are true. So we will usually do multiple balloon dilations during one period, but we've gone to, for like a stricture like this, actually treating 3 times in a week. So we'll do a Monday, Wednesday, Friday balloon dilation, because I feel like if you don't, you're more likely to end up needing a permanent stent in these cases. So for a stricture like this, if we really were going to move forward with the goal of trying to get this completely dilated with a balloon, we would plan on doing 3 separate in 1 week. Yeah, was there another?
Yeah, you just said it, but in terms of diameter,
yeah,
go for waist that disappears and that's it.
Exactly. Yeah, and so the question is about figuring out the diameter and the waist. We use the normal urethra as a guideline, and so if you come back here, and you can see the marker catheter, and I forgot to mention that, but if you come back here, before we place the balloon, you can see the marker catheters in the rectum. And so again, thinking about the marker catheter, this one is just right next to it in the rectum and the colon. The distance between one box and another box, the front of the boxes, is 1 centimeter. It's not always the case, so look on the packaging, but this particular marker catheter, if you measure from here to here, it's 1 centimeter. And so I can calibrate that to know how wide the diameter of the normal urethra is here. So what would that be? Maybe 8 millimeters, 9 millimeters compared to this. So I would say, okay, I'm gonna start with a stent, or I'm gonna start with a balloon that's maybe 5, 6, start small, try to open it up a little bit, see if I can break the waist down. And then I might go to like a 7, 8, try to progressively work it until I get that balloon to open up a little bit more. Rupture. Yeah, that's a good point. So the big concern when you're doing these is that you could rupture. So let's look at what that looks like here in a minute.
Sorry, do you aim to have this fully distended or expanded on the first anesthetic event or throughout?
Yes, good question. So do you try to get it done completely on your first anesthetic? Yes, because I think, based on our experience, I think that if you don't do that, you basically are starting over again the second one. So we try to go aggressively the first one, because we'll see even if we get rid of the waist on the first one, we'll come back on Wednesday and it'll already be kind of strictured back down again. So that's why we've gone more to saying we're just going to do this for sure every single time. All right, I did not forget the question about leakage. Here we go. So here's one that leaked. So this is the same case. And so this is a dog, same dog. So you can see it's dilated now. And we have a little bit more opening, but it's still not completely open. And what do we have? We have a leak. And so that's a possibility. So a couple things you can do. Place a temporary catheter. So if we don't have a stent in stock that we would want to place in this scenario, we'd place some sort of catheter that we're going to leave in temporarily and then order the stent. Or you go ahead and place the stent right away. So this was a case in particular that we had pre-ordered a stent because we had ballooned it previously and it was unsuccessful. So we'd pre-ordered a stent that we were going to place, and so it was a covered stent. This is a benign stricture again, so for the benign urethral strictures, we're placing covered stents. And so, not to say we weren't worried about it, but we felt hopeful that the covered stent was going to work. Usually for these cases, if you get one of those covered stents and you place it, because it has that covering, even if you get a leak, it's enough to close down the leak. The leaks are usually pinpoint, so they're usually small. And so, got a nice little leak here, just barely coming out. We were prepared for this, and so we kind of had this in mind going in to be ready for that. But good questions. Anything else? Yeah, so if it was a cat, we've stented cats in this situation. So usually cats are like 4 or 5 millimeter diameter stents, so we'll place stents in them as well. We would potentially place like a red rubber catheter and suture it in place if we didn't have a stent available, but then plan on placing a covered stent afterwards. Okay, so back to this. So now, same case. We've done our cystourethrogram. We're going to balloon up. So now we know that we've had a little rupture there, so we're going to place this stent. So this is a covered stent. We've gotten a nice long stent because we figured that there's probably trauma expanding beyond the level of where the actual prostatectomy was. And so this stent, again, is covered. And so even though we have a leakage there, just opening the stent is going to be enough to cover over that region that's leaking out. You can see even after the balloon, it's kind of a good news situation, to be honest, how open this stent is. The stent opens to probably about 4 or 5 millimeters in diameter through the stricture, and so that's actually a big win here. That's plenty big for him to urinate through, but probably because it's a stricture, we go back in there, you could place a balloon then, again, inside the stent and then open it up further in that scenario so that you try to maximally dilate it all at the first time. And so this is kind of an example of going the steps through. And so not all of your balloonings end up in stent placement, but you kind of have to think ahead that that's potentially something you might run into down the road when you're doing these. All right. So I wanted to kind of be inclusive of other species. I definitely don't see rabbits and goats all the time, but occasionally I do. So you can do the same thing for those species as well. So for anybody in here that sees a lot of different species, this is an example of a rabbit. So this is a 1-year-old rabbit that had a stone, had a big stricture. You could see a huge urethral dilation. And then right back here in this region, just near the end of the urethra, there's a obstruction there. So we came in with a balloon, again, trying to open that up, and you can see as we balloon open that area, very, very tiny balloon, very challenging to get this into position, but you're able to open that balloon up and break down that waist there as well. And it's not as pretty in this region once you get it nice and open, but you definitely can increase the diameter of the urethra, and it actually worked. In this case, you could see it gets down to the area where the obstruction is, but then eventually they also, as you can imagine, this rabbit was not very well anesthetized. I think it was just sedated for this. And so we kept moving throughout the procedure. But there's other species as well. This is so I happen to see goats maybe 4 or 5 times a year strictly for urethral obstructions. I don't actually see them. I just see them basically when they're anesthetized at that point because I don't know anything else about them. But anybody in here that deals with goats or all of us going through vet school kind of know that goats are notorious for getting stone disease. And the male goat urethral anatomy is just wild. So it's something where they tend to get obstructive urethral stone disease. So we'll see distal urethral obstructions in these cases quite commonly from stone disease. And so when they when they perform PU, here's an example of a PU surgery, perineal urethrostomy in this goat here. And so this is another place that we're using balloons as well. These PUs, I'm amazed at some of the surgeries that they do because these PUs just disappear. And so you could see where that draining board is historically supposed to be, but really it was so hard to find this opening that this goat was really struggling to urinate through it. And so we'll just do a balloon application directly within our visual site. So we'll pass a guide wire up into there again. Sometimes you need to progressively dilate, like a bougonnage technique where you pass dilators up or catheters up just to get it open enough to actually get the balloon in position. But then we'll just pass a balloon here, leave it out halfway out, and you can actually see it and just open up that strictured site. And so this is more of a stricture, or it is a stricture, at the level of the skin urethral junction, so urethral mucosa junction. And so you can use balloons in this situation as well as an alternative. And again, this is a situation where I would plan on ballooning multiple times in 1 week to try to maximize your ability to get that open. Okay, what's another technique for lower urinary tract? This is one that we really like and one that you should think about if you're doing scoping and procedures where it's easier to use a rigid scope. And so who in here is doing endoscopy? Anyone using scopes? Yeah, so a few of us. And so there's some procedures that in males it is challenging to do because of their anatomy. And so it's nice to potentially consider doing what we call a perineal approach or creating a temporary opening in the perineal region. And so most commonly we're doing this for laser ablation of ectopic ureters in male dogs, lithotripsy if we need better access with a rigid scope, idiopathic renal hematuria, potentially for ureteral stent placement, although oftentimes we're doing those percutaneously. So how do we do this perineal approach? Here's kind of a look at the whole procedure, and then we'll kind of come back step by step. But what we have here, perineal access. So we start by placing the patient in dorsal recumbency. And our goal here is to try to dilate the urethra so that we can get percutaneous access into the urethra. So we have the legs forward, we have the C-arm in kind of a lateral to lateral projection, so side to side projection. We placed a urinary catheter into the distal urethra. So we'll place a Foley catheter that sits in this distal urethra. We'll blow it up here. And so what we're looking at on the image on the right is the fluoroscopic image that corresponds to the patient's position on the left. So you have the legs forward here, here's the tail kind of sitting down on the bottom, and we're shooting through directly, and you can see the early contrast cystourethrogram. This is the penile urethra, perineal urethra, and then coming up here into the pelvic urethra. And I'll show one here too, just in case you all can't see. So penile urethra coming in here, perineal urethra, and then pelvic urethra, and then the bladder's up here. And so what our goal is to try to visualize where the urethra is. And so if you look here, this is an 18-gauge IV catheter that we're essentially pushing in just dorsal to the ischium. Here's the ischium here, and what we're trying to do is get access into the urethra just dorsal to the ischium. So we're taking it, and you'll see it's compressing the urethra there. So when we compress it and we know we're in a good spot, we'll percutaneously stick this through the skin and into the urethra. If If you look close, that's the catheter there. So this is the catheter that's been inserted through the skin. We make a small little stab incision into the skin in that location. 18-gauge IV catheter just into the urethra, right at that location where it becomes the pelvic urethra. So it transitions from being perineal urethra to pelvic urethra. 18-gauge IV catheter, so then we're leading with our 035 guide wire on top of that. And then we take that guide wire out and we do serial dilation. So our goal here is to eventually be able to make a hole that's big enough that you can get a rigid scope into it. You can pass something into it that's bigger than what they normally urinate out of, right? This is a male dog, so you're either passing this to help remove stones potentially, or you're passing this to perform another procedure, and so you're trying to get to the larger portion of the urethra. And so we're passing serial dilators here, and you get it quite large. So we'll dilate this up to 14, 15, 16 French sometimes. And so now we've done multiple dilations here, and here's the really big dilation coming in. And so this is a peel-away sheath. So it's a little bit different than the sheaths we looked at earlier. It is a sheath, it comes over a dilator, but what you can do differently is that you can actually take the top part of it and peel it down. So it's a sheath that you put in, and once it's in position, you can break the top, peel it down, and then we suture it here to the skin edges. So we've broken it side by side, and what it means, or what it leaves us, is that it leaves us with the sheath completely inside the pelvic urethra, but it leaves these two little wings coming out that you can actually suture down to the skin. And so you can see now we can get a large scope in there. And again, the main reason that we use this or do this procedure is to try to give us access so we can use the rigid scope in a male dog as opposed to using the flexible scope. And then the peel-away sheath, when you're done with it, you just pull it out, peel it, and then that's what you're left with. And we don't close it. We don't do any kind of suturing or anything, because essentially what you've done is, since you've serially dilated, you've used dilators over the guide wire, you've only spread the tissue apart. So you haven't actually incised the tissue or created a new incision into it. You've just done a stick and you've serially dilating, so you're spreading the tissue apart, so afterwards it tends to contract down. And it'll actually, very rare that we actually get leakage afterwards. So a little bit more, just some other examples here. Dogs, again, same procedure, perineal. Position him in dorsal recumbency, the C-arm angled in a lateral to lateral projection, the urinary catheter to hold the urethra in a dilated position, and then access. Here's after we get access again into the urethra. This is just another example. And you can see the Foley catheter here coming down into the distal urethra. That's what's keeping the urethra dilated. You place that Foley into the distal urethra, you blow the balloon up, and then you can fill up the urethra and the bladder, and it keeps it dilated so that you can get access into the urethra. It's all about access. This is a great example of a Seldinger technique that's in kind of a non-traditional way. Here's that peel-away sheath, so you can see the scope now coming into the peel-away sheath. The peel-away sheath has these two little wings on the edge of it, and that's what you're going to break open, which I think I show here. Scope's going in. So that was a way to get that rigid scope in position here. And then here's breaking down that sheath. Break each side, you just kind of snap it apart, and the edges pull down. It's a long sheath, so you're not losing it. You're just giving yourself access into it in the end, but the sheath's a good, 8, 10, 12 centimeters long, so you're just tearing that most external 2 or 3 centimeters and then suturing those two wings to the edge of the skin there. And then again, the removal is just pulling it out, breaking it off, and then you're just left with your little skin incision there. Questions on that? Thoughts? All right. Let's talk about ectopic ureter ablation then. So there has been some evidence behind this, so it's been looked at. So what we're talking about here is these intramural ectopic ureters. So we actually see a decent amount of these. I think this is probably something that's been misdiagnosed or underdiagnosed for many, many years, and so we tend to actually see a lot of these. Most commonly in these kind of fancier breeds, these breeds that people really find desirable, like Goldens and Labradoodles and those types of breeds, we tend to see this quite commonly. We usually see it diagnosed more commonly in females, likely because males probably with their longer urethra tend to tolerate it a little bit better or show it less. But there are some males that we see as well. And again, for male dogs, we would do that perineal approach to be able to do this procedure. In the couple studies that have come out, in general, the numbers are a little bit scary, but in general, when we're kind of thinking about any kind of treatment directly of ectopic ureters, we usually give the owners about a 50-50 chance that whatever that treatment is going to be successful. And the reason is that we know these dogs have ectopic ureters, and it makes sense why they're urinary incontinent, right? Their ureters are coming in, it's bypassing the sphincter, and they're coming in an abnormal location, so the urethra can't act normally the way that it should to try to preserve keeping that urine in the bladder because it's directly coming into the urethra. And so it should make sense that if you take those down that they would get better. The issue is that it's not always just the ectopic ureter. Commonly, it's not just the ectopic ureters. Most of these dogs also have this urethral sphincter mechanism incompetence, where the actual tissue of the urethra is abnormal. And so that's why we give owners about a 50-50 that this is going to fix the problem afterwards. And so it's a big conversation to have with owners, but it's an important one, and it also comes back to doing a procedure. It's kind of scary to offer a procedure where you have a 50% chance of failure. The flip side is if you don't do it, they're not going to get better. And so this is one where most owners, we kind of get them on board from the beginning, but kind of be very honest with them about the potential outcomes in these cases. One nice thing about this, though, is that the laser ablation is actually a great technique, and it makes us, I guess, feel a little bit better about moving forward with the treatment because it is such a minimally invasive option. I do think that they have the potential to do better with this than the historical surgical options. I wanted to show this one fluoro image. And when you think about ectopic ureters, the vast majority of the cases we see are intramural, which is good because those are the ones that you can treat with laser ablation. But a lot of these cases get called extramural on their diagnostics beforehand because they have a hard time seeing with ultrasound or with CT, they have a hard time seeing where those ureters potentially insert into the urethra or even into a totally abnormal location in the prostate and the vagina or other locations we see them come into. So true extramural ones, I've probably only seen 2 or 3 of those in the last 10 years. They're very unusual. But here's a fluoro video of a true extramural. So it's a pretty cool video. This is a female dog, has an extramural ectopic ureter. So what we're looking at here anatomically is here's the bladder, here's the urethra, and we're doing a contrast study from the distal urethra. This is the vagina coming in, cervix, uterus. Here's the ureter coming in. And so this is a ureter that's truly separate from any part of the bladder and any part of the proximal urethra. Comes all the way down here and actually has a separate opening directly into the vestibule. Excuse me, I said this was vagina. This is actually the vestibule back here. And so it actually inserts directly in. So this is truly an extramural ectopic ureter that doesn't have a direct connection to the bladder. Most of the intramural ectopic ureters that we see, most of them come down and they tunnel down here through the bladder, so they have an opening where it technically should be, and then they end up opening down into the urethra further down the way. And so this is just an example. Keep this in mind. This is a case that we wouldn't use laser ablation on because the idea of laser ablation is that you're opening up that tissue that's closing the ureter into the urethra. You're essentially opening that connection between the ureter and the urethra so that you can reestablish a normal ureterovesicular junction. But in this situation, that opening, that ureterovesicular junction, where it is, it's way back here. So this is one that you would treat surgically. You would go in, incise this ureter, reimplant it up here into the bladder. All right, so how do we do laser ablation of ectopic ureters? So we do a combination of fluoroscopic and endoscopic guidance. And so here's the cystoscopy or the endoscopy. You can see the wire's already in position here. And so our goal with the wire and following it in is to try to find this ureterovesicular junction. So here's the UVJ here, ureterovesicular junction. So essentially we're getting this into the ureter. In this case, most of them are not in the normal, typical ureterovesicular junction. So this may even be a uretero-urethral junction where the ureter is coming into the urethra. And so we've gotten our wire into there. We're trying to work it up so that it actually goes all the way up and into the ureter. And our goal here is that if we're going to be connecting this tissue, that we want to get some sort of protective device in there during the laser. Because what we have going on here, in case you haven't seen an ectopic ureter before, is essentially you have two tubes that are running parallel to each other, but have tissue in between them. So you have your urethra, which you should normally have open, and you have your ureter, which should normally, let's say this is the bladder back here, you should normally have your ureter coming in back here. But what you have is it's connected all the way down here. So you have this tissue in between them. And you want to open up that tissue. So if you open up that tissue, it's going to open up that area caudally or up near the bladder. And so we placed our guide wire, and then we place a protective catheter over top of that. This is called a ureteral catheter. And so then we can actually take our laser, and you can see the first signs here of a laser ablation. We start to take the laser and actually trim back on that tissue. And you're going to see some of that here. And so here's that extra tissue. All of this is tissue that should not be there. And so if you open up this tissue, you're removing a wall of the ureter that should not be there. And so you're going to essentially open the urethra the way that it should be open until it gets to the point where you actually can get the normal ureterovesicular junction. Here's the laser coming in. And so the laser is controlled with a foot pedal. Oh, sorry, it shuts off there. But the laser essentially is controlled with a foot pedal. And then we can deliver the laser power here and essentially cut that tissue to open that up until we get that opening back at a normal ureterovesicular junction. So basically trying to get it into the bladder if we can get it all the way into the bladder. Yeah.
And sorry, do you measure preoperatively how long is this junction where they parallel together?
Yeah, good question. So the
just go by what you see endoscopically.
Totally. Yeah, so the question is, how do you figure out how long that area of tissue is that you need to laser away? So is there a way to do that preoperatively? Not really. There's not a great way, because you can see the tissue coming in with ultrasound. If you did a CT, you could probably measure it and get a feel for it. But until you actually can see that tissue in there and find where that tissue starts to deviate up into the ureter, it's hard to tell. So we'll usually do a contrast study to like outline the ureter. So after we place that catheter up into the ureter, we'll do a contrast study to see where it truly comes down into the bladder. Exactly.
So you have endoscopy and fluoroscopy in the
Same time.
surgery.
Yeah. Yeah, so we use a combination of endoscopy and fluoroscopy. The other thing we can use is we use the other UVJ as an example. So if they're only unilaterally ectopic, which a lot of them are, we'll try to take the one that's ectopic back to the point of where the other one is. So we use that as kind of a guide. Yeah. Great. All right, so what about a little bit of a bizarre one? This is one, honestly, where I think, too, if you start to have some snares and things in your practice, digital radiography, this is an option for doing some of these procedures, so something to think about. So this is foreign body retrieval of foreign bodies that get into the urinary tract. So same idea. Essentially, most commonly when we've seen this happen, this has been for cases that had urinary catheters placed, and the dog chewed it, and then it launches up into the bladder or into the urethra. So essentially you lose it. Historically, way we dealt with that is we'd have to go in surgically and grab it and try to pull it back out again. But a really nice option is just to use a snare to go in and potentially try to grab it and try to bring it out that way. And so again, using kind of an over-the-wire technique to get the snare in position, we get access into the urinary system, so we place a guide wire into the distal urethra. You can also do this in the ureter, so we can place it into the distal ureter. You place a dilator or sheath just to maintain your access, so you're going to place that sheath in the distal urethra so that all the equipment that you place over top of that wire, you don't have to keep getting access again every time. And then you're going to place a snare and a snare catheter. And the way that those two things work together is that you have a catheter that has a little bit of an angle on it, so you can kind of turn the snare in different directions. You pass the snare inside of the catheter, and those two things work in conjunction. So essentially, as you pass the snare outside of the catheter, you now have the snare opening up. It can be a single wire. It's called a gooseneck snare, which kind of comes out in a sideways, or it can have multiple rings coming out. You're basically passing that snare over the foreign body, and after it's over the foreign body, if you pass the catheter over top of the snare, it's going to engage that foreign body within the rings of the snare. So let's look at what that looks like. Here's an example. So this is a urinary catheter that was placed. Our neurology service tends to, they're my best suppliers of these because they tend to place urinary catheters in every back and neck dog that they do. So you get these angry dogs that are down that have nothing else to do, and so they chew out their urinary catheter. And so most of the cases I get to do, every like couple months they'll come to me and say that they have a case, so it's kind of fun for me. But basically this is a down dog that had a urinary catheter in for a period of time, and it launched up and set up in the bladder. So big curled up urinary catheter here. This is after it's actually been grasped. And so after the snare is pulled down, the snare has been passed in over top, and it's actually grabbing it, and then you can pull it out. It's ideal not to, this is one I was having a really hard time snagging. It's ideal not to get it to double over, because then you take down twice the diameter of the catheter through. Thankfully, this was a big enough dog, could tolerate it. But I like to try to grab an end whenever possible, and you can see it just starting to come down into the urethra as well. It's a nice option, though, just for getting these cases out. And again, if you don't have fluoro, you can use DR for these cases. Here's one that's snared in the bladder. This is a really small one. I'm trying to remember what this was exactly, why this went in. This might have just been a urinary catheter. It's a very small one that's in there. But if you look really close, right there, sitting in the bladder. And so you kind of choose your snare size for the job. And so in this case, I used a really large snare, because even though it's a small foreign body, because I wanted it to try to fill the whole bladder. My thought was, if I place this big snare, it's a little foreign body kind of bouncing around in the bladder. If I place a big snare, I can kind of fill up the bladder and take up the whole inner lumen of it, so that hopefully once that snare opens up, that foreign body is going to be somewhere within the arms of that snare. And so opened it up, and then from here, manipulating it around till I get that foreign body in, just getting past it there. And what I'm looking for is I'm looking for the shape of the foreign body to change. I wanted to see that I have that snare around it. And so once I see that, all I do is I leave the snare in position. I don't move the actual snare. I pass that catheter over top of it. And so your snare's there, your foreign body is just sitting through the arms of that snare. And so as you pass that catheter down, it's just going to close the snare down. So basically, as long as your foreign body is sitting through that snare, if you pass the catheter over top, it's going to close it down and engage that foreign body. And so it's a little bit of a back and forth to try to get it around and into position, but we're able to grasp it here. You can see you got the end of it, which is a little bit more ideal than if you kind of double it over. And so we have it here. We see that the foreign body moves, and you are just cranking on that snare. You're really, really holding it tight so that it doesn't lose the foreign body. It's kind of the poor form to kind of get it halfway into the urethra and then get it stuck in the urethra, because it's much more challenging to get out of the urethra. You just have much smaller amount of space, especially with a snare this big. You're not going to want to use a snare this big in the urethra. And so you want to try to prevent that coming in here further. And now we've got a good grasp on it, and we're going to just start pulling it out. Hopefully you can all see that, but there's the foreign body there, and pulling that down in the urethra and out that way. So a really nice option for some of these. Here's one where it didn't launch all the way into the bladder, it just stayed in the urethra. So in this situation, we're just going to use a small snare. And so basically we're getting a snare that's going to be open, that's about the diameter of the urethra, so that when you go in and you pass the snare into that region and you open it up, it's filling the urethra. If you can fill the urethra, then theoretically anything that's in the urethra should go inside the snare. So you basically push the snare up onto the foreign body, you release the snare, the foreign body is going to go through one of the arms of the snare. Same technique to kind of pull it back again. So here it was in the bladder, and then we can grasp it and pull it out, and you'll see it, just the whole thing kind of come down that way. We'll talk about the next topic will be ureteral stents, but we'll pull ureteral stents this way as well. It's a really nice option for ureteral stents because getting to the uretrovesicular junction when there's a stent out is fairly straightforward with the snares. And so we will sometimes pull these stents for whatever. Either they're not working anymore or we place them temporarily on purpose. There's when we do renal sclerotherapy, we place these stents on purpose, and so we'll plan on, or we place these stents with the goal of eventually removing them. And so usually when we're removing them, we're usually removing them fluoroscopically guided like this, where you go in and basically grab the stent and pull it out with the snare. So here's an example of that. So here's the snare. Within the snare catheter, you can see it has a bit of a curved end here. Deploying the snare is going to come out of the catheter, and we're manipulating the end of the snare until we see that it actually engages the ureteral stent. Here it is here, and I'm twisting the snare, and I see that the ureteral stent is now within the grasp or within the arms of the snare, and then I can start to close it down. And once I see that it's in there, I'm going to pass the snare catheter up over top and then be able to grasp it and pull it out. And so it's a nice option to think about if you have these cases, avoids having to do a surgery. If you scope a lot, you can do this instead of scoping. And so for us, it kind of depends who gets to it first. Usually I try to because I like to do this with fluoro, but our internists tend to like to use the scope. So it kind of just depends on who's seeing these cases. And then here's just pulling it out. So again, here's our sheath in position. And as we pull the snare catheter out, this was a cat here. And so I don't know why we're doing it so slow, probably for the camera. But we're pulling the snare cath out here. And then you could see that the stent is right there on the end. And so just a nice option for potentially removing these. All right. Also want to talk about antegrade urethral catheterization. I hope maybe this is one that has a little bit more of an immediate application for you all. This is one that we use very commonly, especially in our ER. Our ER doctors will use this technique. But it's this concept of getting a urethral catheter in a case that's really challenging to get a urethral catheter in. So we'll use this for cats very commonly. But the other thing is that it's really nice for is placing a urethral catheter in those cases that have urethral tears. And so again, kind of coming back to when we see tears in the urethra, most commonly, again, it's our fault, right? We're placing a urinary catheter and we're trying so hard to get a urinary catheter in that we potentially cause a tear. If you think about the angle of that happening, if you're passing it retrograde and you're passing the catheter in, the tear tends to go into the urethra and then track cranially. And so the flap of tissue is coming from retrograde. The flap of tissue is going in this direction. So if you keep trying to come in retrograde and this flap of tissue is hanging down at all, you're going to keep going out of the urethra. Does that make sense? You're kind of passing things in continually in this direction. If that flap of tissue is coming down here and you keep coming this direction, your tendency is to come out of the urethra and out. And so a simple solution potentially to that is to come the other way, to come down this way so that you don't have to worry about that flap of tissue being down and in your way. And so that's when we'll do an antegrade urethral catheterization. It's called antegrade urethral catheterization, but in reality, the only thing you're doing antegrade is getting access. You're getting wire access across that. And so what we'll do in this situation is we'll just come in from the bladder side. So here's just an example of a urethral tear. This was a cat that had lower urinary tract obstruction, and you could see trying to get a wire in retrograde, we were having no success. It was basically continuously going out the stricture that was there, or excuse me, out the tear that was there. And so this wire, we're passing it in and out and in and out, and you can see it's just not going anywhere. Back and forth, it just keeps hitting this obstruction outside of the urethra, and it's not passing forward. So I did a contrast study just to see why it wasn't moving anywhere. And you can see that the contrast immediately extravasates. It goes out of the urethra and starts to fill that tissue around the urethra. This is that periurethral fat tissue around it. And so we knew that we weren't going to get a wire. Nothing goes into the bladder. So we knew we weren't going to get a catheter in that direction. So what we'll do is we will just kind of drape in the bladder and then do a typical cystocentesis. So we'll just take an IV catheter, we'll palpate them. For cats, I usually like to do them in lateral recumbency. In dogs, I usually do them in dorsal just for ease of getting to the bladder. But cats, I'll just lay them in lateral. palpate the bladder. They're usually obstructed, so their bladders are nice and big. Just take an IV catheter, just like we would normally do a cystocentesis. I try to stick at the apex of the bladder so that the angle of everything that's coming down from there is going to head towards that urethral opening. And so you stick an IV catheter in, just like you would normally do, and then down through your IV catheter, you pass your guide wire. And so again, you don't even need fluoro or radiography for this. You can do this just by palpation. It is way easier, I think, because then you know for sure that you're going the right direction. But our ER doctors do this procedure all the time, and they don't use fluoroscopy. So it's definitely something that you don't need to have that available. So here we are, just to kind of orient you to what you're seeing here. The head is on this end, tail is on this end, the bladder is inside here, and this is a 22 gauge IV catheter going directly into the apex of the bladder. Guide wires coming into that. And once we have the guide wire in, since we have fluoro available, here's the guide wire being manipulated around in the bladder. You can see all of this is extravasated contrast coming out of the urethra. And so this was from our previous contrast study that we did retrograde. And so the wire, we're just going to manipulate the wire. It's having a hard time finding the opening, but eventually right there we find the opening and we get the wire to go down and out. So here's the wire then coming out of the urethra. So now we have access through the entire lower urinary tract. So we're coming from the bladder, guide wire down and out through the urethra, and then it comes out the penis on the other end. So now you have access to the wire on both sides, so you can do whatever you want with that. So now you can pass a catheter up over top of that because you know for sure that that wire is in the urinary system. So here's the wire coming out. So this is what it looks like. Bladder side here. Here's the 22 gauge IV catheter coming into the bladder. Guide wire coming in through that. The penis here. Guide wire coming out of that. And so now you know that for sure you're going to be in the urethra, and so you can pass a urethral catheter up over top of that. And so what we'll do is then just come from this side. That's just showing where it's coming into the bladder, and then around here. And then all we do is we have a little Tomcat catheter, like an open-end urethral catheter that we place in over top of that. And then you're just passing that in directly into the urethra. And so in a case like this, that's what we leave in place, and then we could suture that directly to the prepuce. And so in a case like this, when we get a urethral tear like this, we generally don't fix those surgically. We usually will try to wait them out. So we'll usually leave the urinary catheters in 7 to 10 days whenever possible and just let them heal on their own. And the vast majority of cases, that's pretty successful at helping with the tears. All right, thoughts on that, questions? I think that's a nice one that you could potentially, if you're not using that already, potentially something that you could consider using in your practices as an option. All right, so let's lastly talk about one malignant stricture stenting. This is I'd say outside of tracheal collapse in the U.S., this is the procedure that people are most commonly doing when it comes to IR, is placement of urethral stents for lower urinary tract tumors. And so we know that the most common tumor we encounter is this transitional cell carcinoma. Is what it's historically been called, where most people are transitioning the name for that to actually be urothelial carcinoma. It's probably a better description of the type of tumors that we see. Obviously for these tumors, where this is one of those ones coming back to it as an adjuvant therapy for IR, we're doing a lot of chemo, radiation, you can consider surgery, but the options are highly variable and the outcomes are variable as well. So when we think about stenting of malignant strictures in general, we think about, again, palliation. Could be used as a fiducial marker. So sometimes we'll place urethral stents as a guide for radiation therapy for our prostatic tumors. So we'll place them. You think about the location of the prostate is going to be a constantly moving structure. You know, depending on the size of the rectum, the colon with the feces in it, depending on the size of the bladder, the prostate's going to move around. And so if you're doing a high dose radiation therapy directly to that prostate tumor, you get worried about missing it. You get worried about potentially treating some of those other structures around it, some of those other organs around it. And so what you can do is you can place a urethral stent that's not going to move, that it's going to be in the same location as the prostate at all times, and you can use that as your guide. You can actually target that with radiation therapy so that you could specifically use that as a fiducial marker. One other term that I just introduced to you, if you haven't heard before, is this term called a bridge to surgery. Sometimes stents are placed as a bridge to surgery in humans. That is super unusual that we do that in our veterinary cases, just from the cost standpoint and also the goal standpoint. In humans, it's really common for humans with esophageal cancer and colonic cancer to present obstructed or with non-resectable disease. Up to 30 to 50% of people will actually present completely obstructed with esophageal cancer or colonic cancer, and it's resectable in a lot of those cases. And so it's unresectable, if I didn't say that, it's unresectable in a lot of those cases. And so what happens is they place a stent as a bridge to surgery. So they stabilize them by placing a stent to open up whatever the lumen is in order to make them more stable and heading to surgery. And what they found is the surgical complications, the needs for colostomy bags, with the example of a colonic tumor, is much less likely when you stabilize these patients with a stent beforehand. And so I just mentioned that, kind of thinking about the different indications for stents, that's one of the things that you might hear about. One of the other cool things about stents is that if you do have them covered, if you place one of those coverings in them, you can put things into that covering. And so most commonly in humans, this is done for coronary disease, where they're trying to prevent them from clotting off those stents. That's the biggest complication for coronary stents, is that they get thromboembolic disease that closes them down. And so they'll put antithrombotics directly into the covering over the stent. And so we're not at this point in vet med yet, but it's something that we're starting to look at, is that could we potentially put chemotherapy into these stents, into the covering of the stent, and locally deliver chemotherapy directly to these tumors. So I think that's something down the road to consider. So let's just look at a couple examples here. This is some prostate and urethra outcomes. And so just thinking about this, the big take-home points here, the major complication we see with urethral stents in general is incontinence. And so I usually just always warn owners about the chance for incontinence. It's about a 25% rate. These are a little bit older studies. And so now the data that we have probably suggests about a 25% rate of incontinence. And so that's a big number, and it's a scary number, but the reality is the type of incontinence that they get is not this continual leaking, not the incontinence that you see typically with ectopic ureter dogs. It's a occasional leaking throughout the day. And so most owners would rather have that scenario than have, say, a cystostomy tube where you place that and then they have to deal with having a cystostomy tube. So in that situation, most owners still end up electing to place a urethral stent, even though there is the chance of incontinence. And looking at the studies, the median survival times are a bit scary when you see some of them, but all of those are kind of the ones that have the lower median survival times are generally associated with all comers. It's cases that might not get chemotherapy or might not get NSAIDs. When you look at when NSAIDs and chemotherapy are given in addition to urethral stents, the one study that looked at that, the median survival time was 250 days. And the numbers are better than that now. Usually we tell owners when you place a urethral stent, you also follow up with some sort of chemotherapy or NSAIDs. Usually you are looking at probably 9 to 12 months of survival time afterwards. So it's pretty good when you think about that, because when you think about that this is a case that comes in completely obstructed, it's basically in a life or death situation right at that point, moving forward with the urethral stent at that point, and getting good quality of life at that time point is a good outcome. So step by step again, coming back to this, we place the guide wire into the bladder. Males, again, we use a vascular access sheath. Females, it's a little bit tougher, obviously. It depends if they have tumor that's extending down to the urethral papilla or not. But basically need to get that guide wire in position first. You perform that cystourethrogram just like we showed on that previous study. And then you need that bladder to be maximally dilated with contrast so that you can figure out exactly where the stent needs to sit. And then you want to get an idea of that luminal diameter. And so I kind of showed you that in the previous study looking at how we measured for determining the balloon size. But you want to see what the maximum diameter is of the urethra, and you tend to oversize your stent a little bit. You want to imagine that you are making that stent a little bit of a tighter fit than what you're maximally measuring because you don't want it to move. Now, in urethral tumors, it's probably less important than it would be, say, in tracheas. In tracheas, when we're doing tracheal collapse, we definitely need to oversize the stent. But in urethral tumors or bladder tumors, because there's so much tumor there holding the stent in place, that's usually sufficient for keeping the stent from moving. So you're less concerned about oversizing the diameter. However, we do oversize the length, like we showed in that last video, that the length of this we want to be nice and long to the point where it's going to cover over and extend past the tumor in both directions. It's a single hand motion, and so this back hand is not going to move. You can see how small the delivery system is here. And so essentially just pulling off that sheath. That sheath is just pulling off the outside of the stent, and as this hand pulls back, the stent gets delivered. So it's a very, very simple motion of just bringing your hands together. She's watching with fluoroscopy here just to be sure that the stent is in the right position. And again, similar case here. So this is one where it looks like it's ruptured, but it's actually not. So what we often see with prostatic tumors is that the openings, there's always an opening between the prostate and the urethra, right? That's where the prostatic secretions come down and into the urethra. When you get tumors, those openings or those ducts tend to dilate. And so if they dilate and then you do a contrast study, it's really common for us to see extravasation going from the urethra up into the prostate. And so this is just a normal expected amount of extravasation extending from the urethra and up into the prostate. And so we've had our stent coming in here. So here's the stent on the delivery system. And so you can see it in position. It goes from this point to this point here. It's a laser cut stent, so it's going to be the exact same length that it is on the delivery system. We start by opening it a little bit in the bladder. The tumor is right in this region here and extending back to the prostate. We want to oversize it again or leave it in a little bit longer beyond the tumor, opening it back here progressively across the tumor. And then we want to try to make sure we have good coverage so that there's open stent, completely open stent cranial, and completely open stent caudal to where the tumor is. And then just doing a contracystourethrogram here at the end just to make sure that the stent is nice and open. You can see as we're pulling this catheter through, here's the catheter, as we're pulling that back and through, the stent fully enhances with contrast. The whole stent is filled with contrast, so it shows that it's nice and open. And honestly, most of these cases are so open afterwards that usually you can just express them and you see that they have a nice open urethra at that point. All right, here's an example of a bladder and a urethral stent. And so here's a urethral stent. This is a female dog now. Filling defect here all throughout the trigone, so pretty big tumor in this region. You're going to see some filling defect coming out through the urethra. So we're doing our contrast study. And so potentially all this is affected by tumor. You can see a big tumor in here in the trigone region, but then extending back here likely into the urethra. And so we want this stent to extend across that whole length so that we get a nice opening there and coverage over that tumor. So here's the stent coming in. I'm just kind of going back and forth to show you the stent's coming in over the guide wire. And so we're going to open up that distal or that the cranial aspect of the stent to get that part open. We want to get it past the tumor so you can see it stands, it's up here cranially to where the tumor sits. And then as we're pulling that sheath off, it's opening up and coming all the way back. Contrast study afterwards with the catheter, and you see nice opening of the stent in that region. In cats, you can do the same thing in cats as well. It's done exactly, in female cats, it's done exactly the same way as in female dogs. In male cats, the delivery system is too big to get through the penile urethra. So if you do a male cat, you have to do an antegrade approach, so you have to make a small approach to the bladder. Here's an example just in a cat, has a nice big tumor. We probably only see a couple of these a year, so pretty unusual. But cat, big bladder here, filling defect in the trigone. There's all your filling defect from your tumor. And so stents coming in over the wire. A little bit harder to see this stent, it's a little dark bladder. But the stent, we're going to pull back the stent. Opening is going to be right about here. Starting to open the stent. You can see it engaging the tumor and then coming back with a nice opening right in this region here. And that's the region that's most affected. All right, so as far as lower urinary tract applications, I'd say it's probably been the area that's had the biggest progress, one of the biggest pushes for IR in the last 15 years. We're finally getting more case numbers and getting some more studies done, so we're seeing that there is actually a lot of success and future potential with this as a treatment option. And happy to take any questions.
Si alguien tiene una pregunta y quiero usar el micro.
In the male dog, you said that you use vascular access. This is because you do it percutaneously, like you showed the first.
Good question. Yeah, good question. So, how do we? I can repeat it too. Yeah. Whatever you think. In the male dogs, where do we use the vascular access sheath? We actually place it in the penile urethra. So we extrude the penis, place the guide wire up, and then place the access sheath so that we don't have to keep continuously extruding the urethra. And then we just suture it to the prepuce. So we'll leave it all the way down. And then in females, we'll just have it coming up into the vulva, and we'll just suture it to the vulva.
So you also use vascular access sheath for the females?
Yes. Yeah, and so it's a little bit easier actually to do your contrast studies in females. So here's that female case again. And so, let's see if I caught it here. Yeah, so this contrast study is actually through the sheath. If you look really close, you can see the edges of the sheath here and here, and I think it extends up there. So we do it through that side port of the sheath. So here's the sheath here, and we'll inject into that side arm of the sheath and do our contrast study that way. In males, because their urethra is so long, we'll usually place a catheter all the way up into the bladder and do it through a catheter so that we get a good study of the whole urethra. Yeah.
Thank you very much.
Yeah? Anything else?
Más preguntas, o si alguien quiere hacer la pregunta en castellano, evidentemente podemos traducir, ¿eh? No hace falta que sean en inglés.
All right, feel free to ask away. I think we were going to do one more before we break, right? How are we doing on time?
Yeah.
Okay. Oof. A little bit late, sorry.